During a meeting,
I have the essential tremor, and there is nothing more they can do for me.
A tremor is a shake, typically affecting the hands. It may also affect the head, it may affect the voice, it may occasionally affect the leg as well. It is the most common movement disorder. It is one of the most common neurological diseases, bar none.
At 10 years, I lived with the symptoms without knowing it was essential tremor.
You don't want to be diagnosed with something that you can't fix, and that's really frustrating because you're stuck with it. I knew it was going to affect her quality of life. It will become more difficult for her to dress herself, to feed herself. It's hard because I can't always get the backs of my earrings on. And so that's a little frustrating. You have to run to your mom and be like, hey mom, can you put on my own earrings? I'm 16, but can you put on my earrings?
I look in the mirror and try to put makeup on, and the head doesn't want to quit shaking.
When eating super chili with my right hand, by the time I get to my mouth with the spoon, why, it's empty. I don't fill cups and glasses full.
If you've ever tried to read a book and your head is wobbling, you're reading almost every sentence 3 times because you can't follow the sentence across. I'm mostly confined to my recliner chair.
I feel like it comes off as a sign of weakness if you're shaky. People don't understand how to perceive a shaky person. They think they're nervous or they think they're insecure.
At first, it would bother me. 2 tears, having people stare at you is frustrating because you don't know what's on their mind.
It's the small things that kids will notice. They'll be like, Hannah, why are you nervous? You're shaking so bad.
I say that I have an essential tremor, that this has been hereditary in my family, that my grandfather had it, that I'm not nervous, I'm not scared, I'm not weak, I just shake.
And I think that's what essential tremor patients are the most concerned about, is losing our dignity.
I can't go out of the house without holding on to my husband. I'm just useless.
Compared to Parkinson's disease, which is also a field where I work in the last 10 years, we've had about 5 to 7 new drugs for Parkinson's. With essential tremor, we try drugs that we use for other indications, but there has not been that sort of focused research that's required.
It affects daily life. And so if there was a medication that worked better than what's out there right now, it would change everything.
I would give anything if they could find an answer.
see in those patients?
Sadness, anxiety,
What symptoms did you see?
tremor, outside of the physical symptoms, or just?
No, physically, what did you see? They were very different in their appearance, weren't they?
Yeah, some were more central. Some were more.
What do you mean by central?
Like involve the head or the torso, and then others could maintain conversation pretty well. So they had to demonstrate different things that would cause a problem. So you can see the ones that had the more distal upper extremity issues, you can see them demonstrating little more minute tasks like earnings or brushing the hair. Whereas the ones you didn't even have to look at those, you can see them just, you know, the one lady in particular obviously with the reading the head body. So I don't know.
Okay. Any other symptoms that you noticed? Pardon? Vocal tremors. One of the ladies had that. What else?
Depression in the old woman.
Okay. Physically, what'd you see? Anything else?
She put on her makeup pretty well. At least we didn't see her.
Okay. Audrey, well, how did it affect their lives? What'd you hear?
Well, they couldn't eat very well. Like food that they were like, they weren't able to like with the spoon because the old man with the chili.
Yeah.
Soup. And then for the 16-year-old, it was probably pretty, I guess, upsetting for her that she still has to run to her mom for simple kind of tasks like earrings and putting her hair up.
Right. So how do you think that impacts people in just daily life?
They don't want to go out.
Okay, so they might withdraw socially.
Well, and they just need help to do like things that we don't even think about doing. I think that it like is very isolating in a way, and also, like she said, she just feels like helpless, like she feels like worthless, like she can't do anything herself. And so I'm sure that kind of makes you withdraw from people because you don't want to be like a burden or like.
Sure. Sure. What's the incidence of essential tremor? Yeah, some people don't. I've seen it as high as 5% listed, but it's not really good diagnostic. So the variable things that people apply to it or recognize it, so it's up to 5%. Watch when you get in a big crowd. I usually can find one. So now you'll be more aware when you're looking around.
I just realized my grandfather has it, because I never attribute, like when the man was eating the soup, it just was like I was sitting at the
Now you can see that with cerebellar degeneration in older people as they have bad intention tremors. So it may not be an essential, but it could be.
He did play football like in college and beyond, so I was always wondering if that was.
Yeah, could be. Could be. Dip.
Is it just frustrating or is it painful at all?
I think it's just frustrating, more than
Frustrating.
anything. I don't get a sense of. I didn't read anything that related it to pain.
You don't get like muscle spasms or anything like that too?
Not that I know of, but I am certainly not a neuro expert.
If you're young, you get checked for DUI all the time.
Yes, they do. That's true. Did you hear what he said? Say it louder.
If you're young, you get checked for DUI all the time. Like I have a friend who was born with it, and he had to have a special card because he kept getting pulled over and getting field sobriety tests all the time.
Yeah, because which test can they not pass?
Right.
No. Romberg. Well, no, I guess they can pass Romberg. There wouldn't be any reason.
Mostly in their hands, so it's like when he's handing over the license.
Yeah.
They just are like, oh, I better get it.
Sure. Okay.
But
Very
we
good.
pass them.
Thank you. I didn't think about that. Okay, so definition: rhythmic oscillatory movements, constant frequency, variable amplitude, alternating or synchronous contractions of antagonist muscles. Most common of all movement disorders. Clinical features: most of these were seen in the video. The hands, the arms, held outstretched. Usually that is one of the tests that you can do. Tremors in the lower part of the body are uncommon, except as they get older. Patients who've had it a long time can develop gait disturbances, so there may be variations on that. You saw this with the lady. The tremor of the head can be vertical or it can be horizontal. And she had that like side to side, or the no. Tremor can be the only sign, and it's usually early on. It will be the most prominent or early one that people will recognize. And Jenna reminded us that small amounts of alcohol usually will inhibit it. Okay. So, who do you treat? Did you all talk about treatment or at all? Okay. So, it depends on the disability. How disabling is it, or how worrisome or bothersome it is to the patient? So, mild tremors or mild disease does not have to be treated. If the patient doesn't want it treated, then there's really no reason to do that. And then when you get into treatment, you look at when does it most likely occur. So if, let's say, stress brings it out, anxiety brings it out, if it only occurs in certain venues, then you can treat intermittently versus continuously. So that's another thing to look at. If you're going to treat intermittently, some people use alcohol as a way to control, or using propranolol, PRN, can also be used. If you're going to go for more continuous, let's say you saw some of those patients probably needed continuous, then you can treat them on a daily basis. So when to treat, who to treat, symptomatology, how much it bothers the patient, intermittent versus continuous. Okay, those are kind of the decisions. Propranolol and Primidone are both fairly effective. They're considered first-line drugs. And I know this really bothers Dim, but they don't really know why they work. Mostly it's observation. So Primidone's been around since the 1950s. So they found that in people who took it as an anticonvulsant also had a decrease in tremors. So there is no drug that is specific for essential tremors. They are all drugs that are on the market for something else. Propranolol is the only one that's FDA approved. That doesn't mean there aren't a whole host of drugs. So we're going to talk about first and second line drugs. Using them in combination is okay too. And using some of the second line in combination with the first line is being looked at. So those can be considered also. Duration of treatment. So it is a lifelong condition. The drugs work well early on. They don't work so well later on. Usually the best is in the first year of treatment. And then as the disease progresses, then they usually won't have as good control. So that's where combination therapy or changing or switching to other therapy may be of benefit. Okay, so let's talk about propranolol. Let's go down to the bottom of page 3. So the response rate here is about 50 to 75%. It decreases the amplitude of the tremor by about 50%. So it doesn't mean the tremor will go away, but it may make the person more functional. Okay. So you'll see in all of them when they report efficacy, they'll tell you what percent of people have some response, and then they'll tell you usually about what kind of amplitude reduction there is. How these work is not known. Why propranolol of all the beta blockers works the best is not known, but speculated. Propranolol gets into the CNS better than any of the other beta blockers. But some of the peripheral beta blockers also work, so it's probably not all the central, but it may help. So it's thought that epinephrine or the catecholamines irritate motor fibers, and that it's the reduction of that or blocking that actually will lead to, and that's not in your handout, that mechanism. So it's blocking the catecholamine effects on muscle spindles. That is thought to be the reason for its efficacy. Usually when we start treating, you start with, I've given you a range of 60 to 320. That's usually the more end. So most people will start with 10 to 20 a day, or twice a day. So most of the time we'll dose it BID. And then usually up to 16, you see it's got a very wide range, so it can be titrated. Above 320, it's rare that you would have benefit. Is there somebody at the door?
I don't think so. I think this one open.
Okay. So there's twice a day, you can dose it twice a day. The other is that there are long-acting preparations, and so people may prefer those. They are just as effective. So you can use the long-acting. I think I gave you one of those in your prescriptions. So a long-acting propranolol would be reasonable to consider too if people want that convenience. For intermittent therapy, if you're going to use propranolol, it usually needs to be taken about an hour before the event, whatever you're trying to affect or decrease. So keep that in mind. When people use it for anxiety or performance anxiety, it's about the same thing, 1 to 1 hour before. 10 to 20 milligrams is usually the dose there. So the side effects are the same as what we've talked about when we looked at the beta blockers before, as well as the contraindications. So what contraindications would you expect? Who are we not going to use it in? So heart people, okay, so what kind of heart? So heart failure, so the key there would be unstable heart failure. You'll just aggravate it. It is recommended, I think I put a note in there, that if you are going to add it to somebody who has heart disease, is you do it in conjunction with their cardiologist. What other contraindications are there? Asthma, so unstable airway disease, or if they get bronchospasm, that's why you could go with a more selective. Atenolol has been noted to be effective in people who respond to propranolol. What's the biggest non-selective we talked about? The most common. What do I mean when I say a selective beta blocker?
Just like selected for beta 1, yeah.
Not that it goes to a certain place. It's selective for what? Receptor. And for which receptor? Beta 1. Okay. So selective, usually lower doses are beta 1 selective. Okay, so atenolol is one of those. It's a selective at lower doses. But we don't usually start there. People who respond to propranolol, if they do have bronchospasms and they can't tolerate it, you can switch them to atenolol. The rest of the beta blockers, for metoprolol, #1 selective beta blocker we talked about. Not effective, not consistently effective, not recommended for essential tremor. Another one that we talked about was Nadolol. But what do you remember about Nadolol? It's an antiarrhythmic. What class is it? 3. It's a class 3. So class 3s are problematic because of what? What do we worry about with class 3 antiarrhythmics? They're pro-arrhythmic. So those are usually ones that are much more difficult to use. In younger people, probably not so much. But it's one, I didn't put it down there just because it's such a difficult drug to use, one of the more difficult beta blockers to use. Okay. Nadolol is one that you probably don't hear of very often. It is a very water-soluble. Propranolol is very lipid-soluble. That's why it can get in past the blood-brain barrier. Nadolol is a water-soluble. It doesn't get into the brain. If patients really had difficulty with the CNS side effects of propranolol, you could look at Nadolol. It's a peripheral actor for the most part. So propranolol is kind of odd in the beta blockers because it can get into the CNS. It will cause side effects that others you don't see very often. So depression is more common with propranolol. Vivid nightmares, hallucinating nightmares are a difficulty. So if people had CNS side effects, you could consider Nadolol or atenolol as an alternative. Side effects, what side effects do you expect? Bradycardia. So if they're already bradycardic, it would be difficult to use. What else?
Exercise intolerance.
Exercise intolerance. Exercise intolerance, I told you, comes about why? What's the reason usually behind exercise intolerance? It's the heart rate. They can't mount an increased rate in heart rate when you make them do something. So it's usually an exercise fatigue that they're usually complaining about. Is it coming back? Coming back? Okay, so heart rate, blood pressure, those would be big ones if they're already having trouble with those. Diabetes is listed down there. I would say would be a more relative contraindication. We haven't gotten there yet, but the problem with beta blockers in diabetes is that they mask symptoms of low blood sugar. So it would be a more relative contraindication. Okay, moving on to the anticonvulsant stem. So Primidone is, again, a very old anticonvulsant, and it has been noted that it decreases the tremors in patients who were on it for seizures. It decreases high-frequency repetitive firing of neurons. So and that's why it's good in seizures. So it also, that tells you, since you have two different mechanisms of action, that using it with a beta blocker may be very helpful in some patients because they act differently. The problem with Primidone using it is that its side effects early on are really difficult for people to tolerate. It's the long-term side effects with Propranolol that get hard for people to tolerate. So they both have their pros and cons in use. So in terms of looking at response rate, similar response that you see with Propranolol in terms of efficacy, it improves tremors by about the same amount, 50 to 70%. However, response rate is a little bit lower than what you see with Propranolol. Probably 50% or less of people will respond. So efficacy, what it does, it's good at, but in probably fewer people than what we see with Propranolol. Still considered a first-line agent, though. When you start it, we usually dose it at night because it's causes a lot of somnolence, so people get real sleepy. Use low doses to start, usually 25 milligrams, and titrate it up. Probably the dose that is most telling is 250 a day. So if you get to 250 a day and you have not gotten a response, you're probably not going to see a response. If you get to 250 and partial response, you can move it on up to 500. Some of the studies used as high as 750. So it has a very wide range that you can use to titrate. The problem is it has acute side effects that sometimes patients can't tolerate. Nausea can be very significant, confusion, ataxia, all of those are common early on. If a patient has it, you usually have to move on to something else.
You can't give Primidone PRN, can you? Like you can Propranolol?
They don't recommend it PRN because its onset is too slow. So PRN, that's why we do Propranolol for the intermittent. So those are your big two. So the next ones are listed as second line from here on down, Gabapentin onto the next page. Most of them are listed as second line either because they're not as effective or the studies are very small. When we look at the benzodiazepines, they are very effective, but their side effect and their dependency and their tolerance problems are significant. So they're still relegated to a second line. So Gabapentin, we talked about this. Where did we talk about Gabapentin before? Maybe with pain. We'll see it again when we get into diabetes. We use a lot for neuropathies. So Gabapentin in low doses, usually up to about 900 milligrams a day, can be effective. Response rate is about 30%. So you may want to write that down because it'll fit in your one. Tremor improvement is about 30 to 40%. So it's less than what you see with the first two lines. So about 30% of people will respond, about 34% decrease in tremor or tremor improvement. If patients have failed Primidone and Propranolol, it is unlikely that they will respond to Gabapentin. But if you had somebody who could not tolerate the first two, this would be a reasonable one to try. Or it may be also a good one to add on to the first line if they didn't get full response. Probably not so much to the Primidone, but with the Propranolol, it could be used in combination. Okay, next page, topiramate. Topiramate is another anticonvulsant. We're going to see it show up a lot of places. With migraines, it's very helpful. It is now available in combination with another drug for weight loss. It's very anorexic in its action. So here it is again. Its response rate is about what we see with Gabapentin. About 30 to 40% of patients will respond. Improvement in tremor is not great. It's about 20 to 40% improvement. Here's the thing to keep in mind about with topiramate. It's a very effective drug, but it also has a lot of really significant side effects. So let's look at them. So we're going to see it again and again. Paresthesias. So distal paresthesia. So they lose feeling in their fingers, their toes. Anorexia is significant. Weight loss, it says 9 to 12% of patients. I think that's an underreporting. And it's significant. They can lose 10 to 15 pounds. I mean, they just don't want to eat. Another is cognition. It decreases their ability to concentrate, decreases their word-finding ability. One of the students in the class before you was on topiramate for migraines. And she told the class at about 16 they put her on it, and she said within a few weeks, she said, I just couldn't talk. She said, I would go into the room to talk to my mom, and I could not find the words to talk to her. She was a straight A student, grades just went zoom. So it was really significant. I've only seen it used in young women, especially with migraines, and I have seen that happen over and over again. So be very careful in older people if you were to use it because their cognitive ability could really decline. Very good drug. So in the people that can work and they can tolerate it, it's one to keep in mind. The benzodiazepines, there's two of them, alprazolam and clonazepam. These drugs are really effective. You get about a 75% response. Tremor reduction is about 50%. The problem is that the trials that show efficacy are very small and few. So that's why people are a little bit reluctant to go whole hog on them. The other is that they produce a lot of dependency. So they're scheduled, they're controlled C4s, so they produce dependency. You also build a tolerance to them, so you have to keep escalating dose. Abuse is a problem. Withdrawal is a problem. You can't stop them abruptly because they'll produce a withdrawal syndrome. They might be worth considering in people whose tremors get significantly worse with anxiety or stress, if they couldn't tolerate or use propranolol. So I do think they have a place. I sure would keep them in mind because they are very effective, but they're going to be limited at this point. The benzodiazepines bind Gaba receptors. We'll go over this again when we get to other disease states that use, like with anxiety. When you bind to those receptors, they potentiate the neurotransmission of GABA, and GABA is an inhibiting neurotransmitter. Ever had Versed? Ever had a twilight induction of anesthesia? So when we give Versed, we can put you to sleep just like that, and that's because of that action. So very inhibiting. It's why people, when they're on benzodiazepines, may have behaviors that are not acceptable because of that. Okay, so keep that one in mind. The last one is alcohol. So alcohol is effective. The problem with it is that you build a tolerance. You would have to keep escalating the dose. We don't want people to take it routinely. So it's not, the regular use is not recommended to manage the tremor. But again, intermittently, in specific circumstances, it certainly could be considered. My clock stopped. On page 6, so botulinum can be used. There's 3 different types that are available in the United States. Botox is the oldest. You're probably very familiar with it. And it can be used as, it's more of a last resort. I've given you a picture at the bottom. It shows you different places it can be injected to help decrease a tremor. These would not be first line. They'll cause muscle weakness in the hands and the fingers. So they may cause another problem that the person may not want to deal with. But they've been used for head tremor, voice tremor, the hand tremor as well. So another one to keep in mind. Page 7, I have drawn you out a flow sheet in terms of mild tremors, intermittent disabilities, and persistent disabilities. So you can use that one to kind of help you organize the flow of treatment. Questions about those? Okay, let's look at this case history. Okay, so you got a 22-year-old college student complains of shaking in his arms and hands, does not recall onset, but has been persistent or present for a couple of years, seems to be getting a little worse. Severity shaking changes from day to day. Most days are mild and unnoticeable, but on other days his friends comment on it. Nothing seems to make it worse, but it does get better with drinking alcohol. Past medical history is unremarkable. He denies medication, smoking, or recreational drug use. Drinks 3 to 4 beers on the weekend, runs track, works out 6 days a week. Reports that his grandfather and father have the same symptoms. Review of symptoms is negative for weight change, fatigue, weakness, vertigo, headache, fever, loss of consciousness, seizures, paresthesias, or head injuries. On physical exam, he's a lean, well-nourished male with no apparent distress. Speech is clear, posture erect, symmetrical, gait is normal, smooth. Cranial nerves 2 through 12 are intact. Bicep, tricep, Achilles, and patellar deep tendon reflexes are 2+. Is that normal?
Yes.
Okay. With plantar flexion and negative Romberg's. What's Romberg? Close your eyes and balance. And what are you testing when you do that?
Proprioception. Cerebellar function.
Cerebellum.
Balance. If balance or ataxia is due to what? Proprioception. Okay. No evidence of clonus or fasciculations. What are they worried about there? Clonus or fasciculations? ALS? Fasciculations with ALS? He's awfully young now. Tandem walking and heel to shin is normal. Alternating movement smooth. Finger to nose test normal for coordination, but bilateral consistent fine tremor that does not demonstrate increased amplitude with approach to target observed. No evidence of head, neck, or upper or lower extremity tremor at rest. Bilateral fine tremor of hands present with arms extended and held against gravity. Tremor evident when initiating handwriting but does not interfere with task. Muscle strength is symmetrical and normal. Normal, sharp, dull, gogatory sensation of proprioception throughout. Rest of EE is normal. Okay. So, first question is, does he need to be treated? So, talk amongst yourselves, 2 to 3 you in pairs, talk about, look at his symptoms, look at his disability, and then I'll ask you what you think.
I don't think it needs to be treated. It's yeah, I would say you could do like some recorded like methods, like weight and stuff and whatever, but like I don't think that oral.
You're legal.
They can do this beer. I have a doctor.
She said, do I?
Tell us how you really feel.
I guess the morning. Okay, well, I'll talk. Okay, so should this person be treated?
No.
Why not? Mild. Okay.
It's like if he's able to exercise and whatnot, he's clearly not, doesn't have a terrible quality of life or anything.
Then why did he come see you?
Probably because he thought it might be something more serious.
His friends noticed it.
Yeah.
Might want to think about PRN. How many would treat it? How many would not? Okay. Want more information?
If he wanted to go on dates.
What do you want to know before you start treatment, if you did? Vitals, so why would you want to know vitals?
Probably has a low heart rate
pressure, heart rate. What else?
What other meds is he on?
Say it again, talk louder.
Oh, yeah, medication.
I always want to know other medications. Allergies, okay, good. Okay, what would change you the most? So in him, a young person like him, I want to know about asthma. Probably more. Blood pressure and heart rate, I'd be really surprised if it was a problem, but you never know. I want to know about what recreational drugs do you use. So the grandfather and father's history might be helpful. If they've been treated in the past, what was helpful? Okay. Alcohol use. It works.
Yeah.
People will never tell you how much they drink, ever. So I would probably get a little bit more history from him.
Why the recreational drugs? You want to talk about that?
Because they can make you shake.
Yeah,
Stimulant, so cocaine. Or I would also want to know about like marijuana, because you've got, if you're going to use Primidone and you got a centrally acting agent, then I would want to know, am I going to cause more trouble, aggravate, enhance? Illicit drugs are often, if they're buying them off the street, they're often laced with something else. So what have you taken? What kind of reactions have you had? What kind of effect do you get? I always want to know about recreational drugs. They're always part of the formula that they never tell you. So when I ask them, I don't say, do you use, usually I say recreational. Do you use recreational drugs? I never do that. Like, what kind do you use? Hard to say yes or no to that. They have to tell you something. I don't use. Hard for them to lie. It's like with alcohol. I never say, do you drink alcohol? I always say, how much alcohol do you drink? Because then they're going to have to come up with a amount, or they'll lie to you. And it's harder for them to lie, even those that are really good at it. It's just the way we are. Okay. So which would, if you were going to use something, which would be appropriate?
PRM.
Alcohol.
He's of age.
He's 22.
So you could look at the alcohol. You could look at that and talk to him about that and how he's using it in a more appropriate use. I don't think that's wrong. So the propranolol, if you're doing PRN, if it's anxiety, I'd ask him about around his track and things like that. Is that any of that interfering with his performance? That could certainly be, maybe be part of it. If it is, propranolol is the wrong drug because that'll slow him down. All right, so I understand you had your guest lecturer this morning told you differently, so bring those up for me. So they would never use a benzo?
She said that benzo is like her least favorite drug in the world. Personal distaste for it.
Why didn't she like benzos? Okay, she's right, but I'm telling you, I wouldn't throw it out of my arsenal. I'd keep it in mind for those people who it might be the most benefit. Okay. What else did she say?
Botox.
She likes Botox. Why'd she like Botox?
For the last line.
It is last line. That's exactly right. She's right on. What else?
It may or may not help some.
Botox? Oh, that's absolutely.
And it's effective like 3 months, so dosing is also normal.
Right, it is.
And it could cause them to like not be able to speak.
Yeah, depending on where you're injecting it. Yeah, those are all right. She's exactly right.
Added Botox. They did it at the VA. They added Botox onto the medications they're already taking, especially for those with the neck tremors, that they had really good results with it. But it's an added on kind of a thing, and it's only certain places.
And she's a VA?
She was.
She was.
Okay.
Now she's at OSOI.
Okay. What else? Anything else you heard this morning that conflicted with what I told you?
She did more doses of the propranolol, more doses of propranolol.
What do you mean? She
several small doses.
Like the
long-lasting didn't work as well.
You can do that. You
Yeah,
can do
check
that.
the
It doesn't
release.
surprise me. I think the long-acting would work early on for when in the first year or so. I believe that. That they're having breakthrough. Yeah. You could dose it up to 4 times a day if you divide it up. So if they're not lasting as long as you're wanting them, you could do that. You just get into, when we get into talking about migraines and also in treating hyperthyroidism, we'll talk about 4 times a day because people's symptom control is better. But it's harder for people to do 4 times a day. So if you can get them to BID, that's great. I would say that you could do a long-acting twice a day if you're using a low dose. What else? I don't hear anything out that she's saying. Benzos, that's the only thing I would disagree is that I wouldn't throw it out. I'd keep it for some people.
She said that anticonvulsants have minimal effect. That topiramate requires a high dose and it's not well tolerated.
It has lots of side effects, it sure does. Now, Primidone has more data behind it and is more effective than the other two. That's true.
Wasn't it Primidone
Sounds
that caused,
consistent.
like it's a severe flu-like illness?
Yeah. Yeah. But not everybody gets it.
I think it was this that she mentioned, that's from Desert Storm, or coming home with bilateral tremor. And how would you change any dosing to people who are fit, young, and have bilateral essential tremor instead?
Okay, so what was the original part? You said something about...
Oh, just veterans from Desert Storm are coming over and it's an unknown etiology, but normally it's unilateral, and they're coming back with bilateral and they're not really sure what's going on. Just, do you have any insight on what might be causing that, or what you might do to tweak the medications to fit those people specifically?
Because she brought up how the beta blocker, they already are fit and healthy and have a low heart rate, so when she would beta blocker.
That's the other thing is you use a beta blocker in young men, they're all going to complain of impotence. They won't use it. So that's a real trouble. That becomes more difficult. The Primidone you could certainly start with, but they're probably going to not like it because of the sedating qualities of it. You could try Gabapentin. You could certainly do that. Topiramate. I've seen more of the anorexic in women than I have in men, so that might be one to consider.
You just want to really lose
it's hard.
if are running. You know what I mean? Like that's
Right.
a huge thing.
It is.
Is there like a?
It's a hard one. Botox might move up the line on that one. Interesting. Anything else from what she brought up?
Would you just try one and just kind of see how it works?
Absolutely.
And just see what the side effects.
Yes, yes.
So would you start with the first one?
I would start with the first line. Most data, highest demonstrated efficacy, unless you're enhancing side effects or you've got a contraindication. I'm always in favor of using the smallest amount of drugs, the least amount of dosing. Usually, when you start 2 drugs and you have trouble on those, which one is it in deciding? People will always have, well, they will always, very low doses of 2 drugs can be advantageous. I always think it's better start with 1 drug, see if you can get effect. Titrate it up until you can't get effect or they have side effect, then add another drug. Okay. All right, let's take a break. We'll come back at 2 and we'll pick up Parkinson's.
Are you going to go check on Stacy, sir?